Hi, my name is Christopher Kaczor, and I'd like to thank the Academy of Catholic Thought and Imagination for a fellowship opportunity last semester. In connection with that fellowship, we were planning on having a public discussion and lecture about my research. But unfortunately, given the COVID epidemic, that wasn't possible. So in lieu of that, what I'm going to do is have a conversation with my LMU philosophy colleague, Catherine Peters. She was very kind and read the paper and has also come up with a number of questions for us to talk about. So the paper that she read is called "Why Medical Professionals Have No Moral Claim to Conscientious Objection Accommodation in Liberal Democracies." And this paper is written by Udo Schucklink and Ricardo Smalling. And in the paper, what I do is offer a number of reasons that they give to reject conscientious objection in healthcare. To provide a little more context, in healthcare, there are some controversial procedures, such as abortion. And so there are some doctors and nurses that decline to cooperate in, say, providing abortions. And in the article that I'm criticizing, the authors say that this declining of providing these procedures, that is to say, this conscientious objection, is unwarranted and unfair. And so they say basically that healthcare providers who don't want to provide abortions should either provide those abortions or should get out of healthcare entirely, should quit the healthcare profession. So that's the view that I'm talking about and checking out. And Catherine, as I said, has been very kind in reading my paper and offering to talk about it with me. So without further ado, I'll pass the baton to Catherine and we can start our conversation.
Thank you, Chris. And thank you for this essay. It was remarkably clear and informative, so it's really a great pleasure for me to be able to speak with you about it. The first question I had is, in this essay, you're very clear that you're not arguing for or against the ethical permissibility of, for example, abortion. Do you think, though, that arguments about conscientious objections ultimately reduce to these arguments? It does seem like in the essay you're responding to, they assume the ethical permissibility of actions like abortion, which is really besides the point of, it's begging the question of what a conscientious objection is. So do you think that the arguments for conscientious objection ultimately reduce to questions about the ethical permissibility of these, or is there a way to distinguish them?
So I would say there is a way to distinguish the two. It seems to me that someone could say that I personally am in favor of legalized abortion, and yet also consistently recognize that we shouldn't force doctors and nurses who do not want to do abortions to perform abortions. So that seems like a logically consistent view. And if we think about not moral permissibility, but legal permissibility, we find that view in the law in the United States. So in the United States, abortion is legally permitted, but also in the United States, it is legally permitted for healthcare professionals to decline to provide abortions. Mm-hmm. So I do think, obviously, that the moral questions are linked up to questions about conscientious objection, but I think that we can distinguish them, and I think that there's no logical inconsistency in holding both that, say, abortion is ethically permissible, and also holding that healthcare providers ought not to be forced to provide abortions if it goes against their conscientious objection.
Okay, no, that really helps clarify, I think, because it seemed throughout the other two authors' arguments that they are, of course, assuming the permissibility of this, but that itself is begging the question of what conscientious objection is about. But it seems what's fair just for one side that's conscientiously objecting would also be fair even if you support performing these actions.
Yeah, and we could think about the same topic in terms of war. So we do allow conscientious objection for those that are drafted into war. And so during World War II, for instance, there were some people who declined to participate. And it seems to me you could have the view that World War II was a justified war, but also have the view that if you're a Quaker, for instance, you ought not to be forced to, participate and kill people and things like that. So it seems to me those two views, again, in terms of a different issue, in terms of war, I don't see at least any necessary inconsistency in those positions.
Yeah, that's very interesting, actually, the example you just brought up, because what I was wondering as I was reading through your essay is while you were responding to objections in regards to healthcare, it seems like the underlying principle of conscientious objection is not necessarily limited to cases of healthcare. Examples of war also seem to follow the exact same arguments, or perhaps not the exact same, but the same general principles. Um,
Yeah, so in a pluralistic country like our own, there are some religions like the Quakers who, in principle, think that all violence is morally wrong, and they believe that God has commanded them not to use violence. Now, if you had that view, then it seems to me it would be pretty hard to see how you could be a soldier fighting in the trenches, because you'd have to shoot people and things like that. Now, you could participate in a nonviolent way, right? You could, for instance, be a medic and care for those who are wounded. And so that would be a way you could participate. But it seems to me that if you were to try to force a Quaker, say, not just to be a medic, but to be someone who's firing a cannon or whatever, yeah, I'm not sure how that could fit with the Quakers' religious conviction. Now, in the United States, at least, we have a pretty long tradition of tolerance of various religious positions, and we haven't, at least historically, forced, say, the Quakers into combat fighting positions. And arguably, that is part of the legitimate pluralism and legitimate respect that we accord people of different faiths. Now, I wouldn't want to reduce the conversation we're having now about conscientious objection in healthcare simply to a matter of faith, because it's also the case that there are some non-religious, atheistic people who nevertheless object to abortion. In the paper, I talk about one famous case of someone named Bernard Nathanson. He was the founder of the National Abortion Rights Action League, and he himself performed something like 30,000 abortions and oversaw many others. But in the early 1970s, after the advent of ultrasound technology, he came to believe that abortion was violence against prenatal human beings that he could see through the ultrasound. And so he stopped performing abortions and he became very pro-life. But he was, at that time, an atheist. Now, whether your conscientious objection arises, as it did for Bernard Nathanson, from an atheistic perspective, or whether it arises from a religious perspective, at the end of the day, I'm not sure that's really morally relevant. In either case, the person has a conscientious objection to doing this activity. And so whether your conscientious objection is ultimately grounded in just reason alone, or maybe your conscientious objection is ultimately grounded in a religious perspective, I'm not sure it really makes a decisive difference for the claim that in conscience, I can't perform this or that action.
Thank you. No, that was a particular issue that I thought was really helpful to point out, which is a lot of the arguments that these two authors seem to bring up assume both the permissibility of these actions, such as abortion, and also they seem to view the reasons for conscientious objection as religious or even idiosyncratic. And your distinctions there about how we can distinguish between legitimate and illegitimate, and the value that religious reasons bring outside of just religion was really helpful. Another doctor that you mentioned that I thought was really interesting was Dr. Makenzua, right? And so, when we're talking about Quakers' religious objection to participating in war, that doesn't mean that there are not other ways that they can participate. And in fact, forcing them into military service would mean that they couldn't perhaps serve as medics. Dr. Makenzua, I thought, was an interesting example as well, because there's this woman who is, a trained OBGYN. She is of great value to the community that she's serving, and forcing her to go, to give up her conscientious objection to performing certain actions seems to actually harm the community that she's uniquely poised to serve. I was wondering if you could speak a little bit more about that, which is mainly the point that even if someone is religiously motivated, that there are other reasons that they might object, and there's other valuable services that they can provide, which might be precluded if they're forced into performing actions that they object to.
Right. So the example I was talking about was of a Muslim doctor in Los Angeles. And so the idea would be that she is connected to her home country, and so she serves many of the Nigerian immigrants in Los Angeles. And if these proposals were put forward and made into effect, basically what would happen is she would be forced out of the medical profession, because as a devout Muslim, she believes that she should not perform abortions. Now, what would take place if that happened? Well, obviously this would harm her. And in this case, she has children and a family, and she's a sole breadwinner, so it would harm not only her, but her whole family. But in addition to that, it also harms the immigrant community, because sometimes people choose their healthcare provider on the basis of a shared culture, a shared background, and that really enhances healthcare, because if you go to a healthcare provider that shares your values and background and culture, they're going to understand where you're coming from better, you're going to understand where they're coming from, it's going to facilitate honesty and openness, and it's going to really enhance healthcare. So what happens then if she's forced out of healthcare? Well, what happens is all these people who were able to rely on her services, who were able to obtain actually better service because of the distinctive relationship that she could have with people from her native land, all those people are deprived of that opportunity. And in this case, it doesn't even help people that are seeking abortion. In Los Angeles, there are dozens of abortion clinics. So it's not at all the case in Los Angeles that, someone who wants an abortion just can't find one. So what happens then if this kind of rule against conscientious objection, if it's implemented, is that it helps no one, because all the people that want abortions can already get them. There's tons of abortion clinics in Los Angeles. And it harms greatly the individuals that are affected, the doctors. And then it also harms all the people who rely on these healthcare professionals. So basically, if you have a consequentialist analysis of conscientious objection, I think that if you really take into account all the consequences, it turns out that even on a consequentialist analysis, that conscientious objection is something that we should uphold rather than abolish.
Yes, that was another point that I was wondering if we could talk about, namely this idea that if we abolish conscientious objection, it seems like it would not for very long just apply to practicing medical professionals. It would also impact, say, students who are considering going into medical school, residents who are completing their studies. When you're arguing against conscientious objection from a consequentialist view, though, it seems like they're picking and choosing what consequences matter. I was wondering if you could expand a little bit on how the medical profession, or indeed even other service organizations, might be impacted if we exclude people from the very field based on conscientious objections.
Yeah, that's a good point. So in the United States, you have about 20% of the population or so who describes themselves as strongly pro-life. Mm-hmm. So if conscientious objection is completely forbidden in the healthcare professions, what that would mean is that some percentage of potential medical students wouldn't be able to get into medical school and get through medical school. So for example, one proposal is that part of medical training would require all students to spend some time performing abortions. So if that did become a requirement, you're going to have some percentage of people that say, well, I guess I just can't become a doctor. And if you have a single factor analysis and you say, well, all that matters is promoting abortion, well, then you might say, well, great, that's a good outcome. But if you don't have a single factor analysis, if you say, for example, that general quality of healthcare professional matters, then it seems to me that the exclusion of these people from the healthcare profession, 20%, whatever percent it is going to be very detrimental for the entire healthcare profession. So for instance, if you have a medical school class of say 100 people and 20 of those would have gotten in, they had better grades than others, they had better recommendations than others, they were better qualified than others. And then because of these lack of conscientious protection, those 20% either aren't admitted on that basis or don't apply. Well, then what happens is those 20% are replaced by 20% that were below standard, right? So some people that were on the A team end up getting replaced by some people who are on the B team in terms of their academic qualifications, in terms of their abilities. And so that adversely affects all of us. I mean, if I go in for surgery, brain surgery, I want someone on the A team. I want the very best person I can to do my brain surgery. And if it turns out the very best person to do my brain surgery is someone who also objects to abortion, well, that's fine with me. And it should be fine, I think, with everybody who goes in for surgery.
Mm-hmm.
So the single factor analysis that the only thing that matters is promoting abortion, if consistently applied, would end up adversely affecting healthcare for everyone in terms of the quality of healthcare. Because again, there are going to be some people who would be admitted to medical school, who would turn out to be great at brain surgery, great at whatever, who won't be admitted. And then people who, again, otherwise wouldn't be admitted and will end up getting admitted.
Mm-hmm.
But the other factor is not just the quality of healthcare, but the quantity.
Mm-hmm.
So in the United States, about 20% of healthcare is provided by the Catholic Church. The church has had a very long history of providing healthcare, particularly for poor and disadvantaged and immigrant communities. This goes way back to the 19th century. Now, if conscientious objection is abolished, if all hospitals are forced to perform abortions and all doctors are forced to perform abortions and nurses, well, then again, you're going to get some percentage, let's say 20%, that are not going to go along with that. And so they will have to drop out of medicine. Now, what happens in a situation where you have the number of healthcare professionals and the number of healthcare institutions like hospitals dropping out of providing healthcare? Well, if the price of something is determined by supply and demand, well, presumably the supply of healthcare matters. In other words, the number of healthcare professionals, the number of hospitals and other centers of healthcare. And so if you take away 20% of the supply, and presumably the demand for healthcare is going to stay the same, or in the United States, frankly, the demand for healthcare is going to go up because you have the baby boomers getting older and older, and the older people get, generally the more healthcare they need. So we have an increasing demand for healthcare, and if we abolish conscientious objection, we'd have a decreasing supply of healthcare. Well, that's going to raise healthcare costs for everyone. So this single factor analysis of some people that the only thing that matters is promoting abortion, no matter what, is going to, if successful, undermine both the quality and the quality of everyone's healthcare. Whether you're pro-choice, whether you're pro-life, whether you're somewhere in the middle, everyone is going to be adversely affected if these policies go through.
Yeah, you know, this was a really interesting point. And I have to say, it was a part of your essay that I read with different eyes now in 2020 than I would have, say, in 2019 or earlier. Because when you're talking about some 20% of Americans identify as pro-life, therefore would not be accepted to medical school or would not go. And then, even say the Catholic institutions, just to name one religious group, which would possibly shudder if forced to overcome these objections. That perhaps would seem like, okay, well, 20% less. I still don't have to usually wait in line to see a doctor. But now when the sort of global awareness of hospital institutions is raised, in a pandemic, 20% fewer doctors, 20% fewer nurses, 20% fewer institutions could have significant implications for something that's completely unrelated to any of the typical issues of conscientious objection. This was particularly in LA, right? Shut down, lockdown in order to not overwhelm the healthcare system. Even with the healthcare system in place that we have now, there were worries that we might overrun it with something completely unrelated, right, to COVID. And so when I read this part of your essay, I wonder, oh my goodness, what would happen if there were not those 20% of doctors, those 20% of institutions? And especially, I think the point about certain institutions assisting the underprivileged. We see in the numbers with COVID that there are indications that the people who are hardest hit by this, global pandemic are precisely those groups which do not have access to all of the resources that are available, perhaps, that perhaps are lower socioeconomic levels. This seems to go directly towards the quality and quantity of care that they might receive.
No, I think that's exactly right. And at least Catholic institutions historically really have focused on often immigrant communities. So many of these hospitals were founded in the 19th century, and they were founded for primarily the Catholic immigrants that were coming over from Italy, coming over from Ireland, etc. And the church has continued this sort of outreach to immigrant communities. So when you have global pandemics like we're experiencing now, the demand for healthcare needs to be in place, right? Because healthcare is a good that you can't just whip up on demand, right? In other words, if you're missing 20% of doctors, you can't just snap your fingers and send someone to boot camp for 6 weeks and they become a doctor, right? I mean, obviously it takes years and years and years. And the same thing's true for institutions, right? You can't just make hospitals just appear on demand. So it seems to be very short-sighted not to take into account the possibility of things like that's happening now, pandemics and such. And we're going to be better equipped to face those difficulties if we have, you might say, our healthcare, set up in such a way to really maximize its benefit for those who are needing healthcare, and particularly those who are in greatest need. So, yeah, I guess part of the reason I push back on efforts to abolish conscientious objection is that I think the actual real world consequences for that would be extremely detrimental. Again, not just for people that are pro-life, but for everybody. I mean, I think everybody would be adversely affected if these policies came into effect.
Right. It's interesting. In our discussion so far, we've been largely talking about the role of Catholics medical profession. But the doctor that you mentioned is Muslim, right? I was wondering, in your experience, is Catholicism the primary advocate for conscientious objection? It seems like this is an issue that would apply to other religious traditions and even, atheists, people who do not have any religious convictions. This would seem then to be perhaps a strong point of agreement. The idea that we should follow our consciousness does not seem to be particular to Catholicism. I was wondering if you had any thoughts about that issue.
No, that seems right. And it seems to me that all people of faith, at least all people of monotheistic faith, think that they ought to try to love God and love neighbor. And part of loving God and loving neighbor for the three great Abrahamic faiths would be to refrain from doing certain actions. For instance, shedding the blood of the innocent, defrauding the laborer, raping people. I mean, there are certain actions that are, you might call them intrinsically evil. And those are the kind of actions that in principle can't be ordered to love of God and love of neighbor. So Jews and Christians and Muslims alike all believe that there are certain actions that should never be done. You might say all of them believe in conscience that even under pain of death, they ought not to do certain actions. Now, this view is also held by some people without faith. In other words, this is not something only people of faith believe. In fact, I would say all people of goodwill, if they think about it, would come to the conclusion that there are some actions they ought never to do. So think about, say, the ancient Greek story of, was it Sophocles? Who was the one, now I'm drawing a blank, you might remember. Who was the one who, the woman who wanted to bury her brother?
Antigone.
Antigone, that's right, yeah, I couldn't remember her name. So in that story, right, she had a conscientious, in her conscience told her that she had a duty and an obligation to do this action. And then you get secular people, atheistic people like Bernard Nathanson, who believed that he had a conscientious objection not to perform abortions. And so I wouldn't want to I wouldn't want to say that it's only people of faith that have these conscientious objections, because there are people, good people of goodwill, many people of goodwill. In fact, I'd say probably almost all people of goodwill who would say something like, look, there are some actions I'm just never going to do. I'm not going to do racist actions. I'm not going to do misogynistic actions. I'm not going to do actions that are cruel and exploitative of others. So I don't think you need to be a person of faith to recognize that, there's certain actions we should not do. And that's another way of putting the point that you don't have to be a person of faith to obey your conscience.
Mm-hmm.
Now, it might be the case that in faith traditions, there's a more developed reflection on exactly, what actions are the kind of actions you should never do. And there is maybe a more developed reflection on exactly how conscientious objection relates to, broader philosophical, metaphysical, religious claims. But I don't think at all, I think, again, all people of goodwill recognize, you shouldn't do certain actions, even on pain of death. And so that's another way I think of saying that all people of goodwill have a conscience, and all people of goodwill recognize they should follow their conscience. And so really the issues we're talking about aren't uniquely or distinctly Catholic. They would apply to, again, all people of goodwill.
Yeah. A distinction that you raise, which I think gets at this point also, is the really important, I think, distinction between, say, conscientious objection to certain kinds of practices and conscientious objections to treating certain types of persons. And conscientious objection really applies to particular kinds of practices. And this is important, I think, because it can counter some of the worries that certain groups of people, women say, right, are sort of adversely affected by conscientious objection because, a man never goes for an abortion and is turned away. And so I think it's very important to recognize the distinction between perhaps discriminating against a person, someone refusing to see perhaps Black patients or refusing to treat women at all, and refusing to perform certain kinds of practices. Could you expand a little bit about that distinction?
Sure, yeah. So the idea of conscientious objection in healthcare is not about discriminating against people, but rather about, you might say, discriminating against certain practices. So the idea, let's think about euthanasia. The idea would be this: if I'm a doctor who objects to euthanasia, let's say I'm a doctor who thinks that as a doctor, I took a Hippocratic oath and I promise not to kill others. As a doctor, I think the goal of my profession is healing, not killing people. As a doctor, I want my patients to trust me 100%. And if the patients think that I actually am open to killing them, that may not enhance their trust of me. So let's say I'm a doctor who conscientiously believes that I ought not to kill my own patients. That belief is about the kind of actions I shouldn't do, namely killing my patients. It's not about the kind of patients I'm treating. In other words, I would be consistent in terms of opposing killing my patient if my patient was a man or my patient was a woman, if my patient was white, if my patient was Black, if my patient was Asian, if my patient was Hispanic, young, old, it doesn't matter. In other words, it's not at all about the kind of person who's asking me for this procedure. It's about the kind of procedure that is requested. So it's not discrimination against persons. At least people that are consistent in their conscientious objection would say, look, I don't provide treatment X for anyone, regardless of any race, religion, culture, creed, age, Vietnam veteran status, regardless of any characteristic you can think of. I don't kill my own patients. I don't provide this treatment or that treatment. So again, it's not about discriminating against persons, but it's about refusing to perform certain treatments.
Yeah, and to pick up on something that you mentioned about the goal of physicians, staying within healthcare here, the goal of physicians is to promote and foster the health of them. I thought that you're mentioning in the essay the objective way, perhaps, of differentiating between legitimate and non-legitimate forms of conscientious objection by appealing to what the medical profession is aimed at, right? It's aimed at fostering the health of the individual. I thought that was really important, and reminding ourselves that that is the purpose of this might help a little bit in distinguishing or allaying the fears of, well, if we allow conscientious objection in this one instance, then how am I to know that someone's not going to look at me when I walk into their office and refuse to treat me for, I don't know, my broken foot just because I'm a woman? Could you speak a little bit more about how it is that we can distinguish between legitimate and illegitimate forms of conscientious objection?
Yeah. So the way I try to do in the paper, at least, is to think about what is the purpose of the medical profession. And you might distinguish between goods internal to the profession and goods external to the profession. And here I'm drawing on a distinction made famous by Alistair McIntyre in After Virtue. So if you think about goods external to the profession of medicine, you might think about, say, making a lot of money. But that's not really what medicine in itself is for, right? Because making a lot of money, you can do that like being a philosophy professor, right? I mean,
I got into it for the big bucks.
I did too, exactly. I thought, what would maximize my income? Philosophy, that's the way to go. So, any job can make money, right? Lawyer, doctor, investment banker. So yes, it's an external good of medicine to make money, but that's not the internal good of medicine. So what is medicine as medicine aimed at? It's not making money, it's not being powerful, it's not any of those external goods, but rather, it seems to me at least, it's about health, right? That's the good internal to medicine that doctors ought to aim at. And so then the question arises, well, what is health exactly? And there's different debates in bioethics about how to define health. Some define health in you might say, a very holistic way. And they say the health of the patient is best understood as any good that contributes to the patient's well-being, social, emotional, physical, etc. And I actually reject that understanding of health because I don't think the goal of a doctor as doctor is my overall total good in every respect. Because for instance, at least I believe that part of my good is friendship. In other words, I think that my life would be very seriously undermined if I had no friends at all. And I just was, just totally deprived of the company of others and good relationships with others. But I would not say that the goal of a doctor as doctor includes enhancing my friendships. In other words, if I go to the doctor, it's not the doctor's job to say, hey, Chris, you need some more friends. So let's, I'll sign you up for the bowling league and you can join the philosophy club. And, there's this nice philosopher, Catherine, I'll introduce you to her and you can talk philosophy with her. Like, that's nice if the doctor.
I wish they were that way.
Yeah. I mean, it would be fine if the doctor did that, but that's not really the job of a doctor, right? In other words, the doctor's job as a doctor is not to enhance my social life. So what is the job of a doctor as doctor? Well, it's not to enhance my social life. It's not to enhance my financial well-being. It's not to enhance even my spiritual well-being. The real job of a doctor, I would say, is to focus on health as my bodily well-being. My physical well-being is what the doctor is aiming at, helping me to become more healthy in a physical, biological sense. In other words, health is a good, I would argue, that is shared with human beings and other animals. In other words, you can look at a dog and you can say, this is a healthy dog. The blood pressure of this dog is, just what it should be. The dog has got no diseases. The dog is able to do all its dog activities very effectively. And you can say that dog is healthy. And I think in a similar way, you can say that about a human being, that I'm physically healthy if my heart is pumping blood effectively, my lungs are able to breathe oxygen properly, I'm able to do the physical activities that I need to do, like, walking around and running and talking and reading and whatever. And malfunctions of health are partly, diseases, are partly what a doctor is aiming at. And a doctor also aims at not just getting rid of diseases, but also promoting health. In other words, helping to ensure that the proper functioning that I'm enjoying right now is going to continue, hopefully for a long time. So again, it's part of the doctor's role to say, hey, if you want to maintain the strength of your body, you need to exercise 3 days a week for an hour a day or whatever it is. If you want to maintain a healthy blood pressure, you better eat your, oatmeal or kale or whatever lowers blood pressure. To that. So, but the goal of the doctor as doctor, the internal good of medicine, I believe, is physical health. So how does this relate to conscientious objection? I think you can differentiate legitimate conscientious objection from illegitimate conscientious objection, perhaps in part by means of health understood in the way I'm describing it. So why is it a legitimate conscientious objection for a doctor to decline to kill a patient? Well, that can be explained in terms of the good of health. Health is a good that comes in degrees, you might say. In other words, you can be perfectly healthy, you can be pretty healthy, but got a few things wrong. You can be really sick, you can be about to die. But what's the maximum of lack of health? Well, I would say the maximum of lack of health is actually dying, being dead. In other words, nothing's functioning right, right? In other words, the heart isn't working right, the lungs aren't working right, the whole thing is just completely not working right. So for a doctor to kill a patient is for the doctor intentionally and deliberately to do the opposite of the internal good of medicine, the opposite of health, to inflict, in other words, the maximum of lack of health, which is death. So a doctor, I believe, can legitimately say, hey, that's not within the scope of my job, right? My job as a doctor is to promote health, to restore health. My job as a doctor should not be the opposite of that. So it'd be a little bit like a teacher. I think that the goal of a teacher in part is to help students gain insight and gain knowledge. So imagine a teacher doing the exact opposite of that, undermining the knowledge of students, giving them all lobotomies or something. Like, that's exactly the opposite of what a good teacher should do, right? I mean, our whole goal is to help people, hopefully to understand, to gain insight, to gain knowledge. And so we should never act against that good. And so I think if we think about the good of health, objectively understood, then we can differentiate legitimate objections in certain healthcare procedures, on the one hand, from illegitimate objections based on conscientious objection. So in other words, if someone said, hey, I don't want to provide antibiotics because I, just have a thing against providing antibiotics. It seems to me you could say, well, does providing antibiotics help, in some cases, objectively speaking, the health of the one who gets the antibiotics? And I'm not a doctor, but as far as I know, all available medical evidence says that yes, in certain cases, giving someone antibiotics greatly aids their health. So that would, if someone conscientiously objected to that, that, it seems to me, might be an illegitimate conscientious objection.
No, I think that's really important. And to follow up a little bit on the example of teachers not lobotomizing their students, which I of course agree with, it seems to me that when we say conscientious objection, it's often within the area of medical ethics, probably because there are so many instances that come up. But at least the authors of the essay you're responding to seem to assume, at least implicitly, that this conscientious objection is motivated by some sort of principles beyond medical. And so I was wondering, do they make any mention of conscientious objection that is not religious or even principally motivated? I'm thinking here of the example of euthanasia, and her name is escaping me, but a few years ago there were these accounts of this young woman, not in the United States, who opted for assisted suicide. And she was very young and otherwise good health, but in her past was serious abuse. All right, so she had been traumatized. There were mental problems that she had, and because she decided that the only way out of this legitimate pain was suicide, and the country that she was in had that legalized, she could go beyond her physician's objections to it, which seems to be, as you were saying, going directly against this idea of the goal of health, which is to restore the health of the human being. And I wonder, do they make any sort of reference or indication that there might be non-religious or non-principled objections, but perhaps medical objections to administering care that a patient insists on because the patient, who is not the physician, has decided that this is what they want, even against the objections or the advice of medical professionals? Do they mention anything? Do you have something to say?
Yeah, they don't mention the cases you're talking about. And I think you're right. In some cases, conscientious objection could arise not from an ethical principle, but from, you might say, a medical judgment. So medical professionals do not always agree about what the best course of treatment is for any given disease or any given situation. So it seems to me that you do have, again, another instance of legitimate pluralism where medical professionals can and do disagree about the effectiveness of certain treatments for certain conditions, about the effectiveness of certain medications, about whether or not surgery is going to be warranted. I'm told that among surgeons, they tend to think that, well, everything's cured by surgery. They want to use the knife for everything. And then non-surgeons are much more skeptical of that and say, well, hold on. I mean, surgery itself has, its own risks and its own drawbacks. So I think you're right. Another dimension of this is to say, you could imagine some medical professional saying something like this: look, in my medical opinion, I don't think this treatment is going to be beneficial. I think the risks of this treatment outweigh the benefits of this treatment. and so I'm not going to provide this treatment. So if we talk about a controversial treatment, abortion, there are some medical professionals, some doctors who believe that the physical and psychological effects of abortion are greatly detrimental to the women who undergo abortion. And so if you had that view, then it seems to me that you would be justified in saying, hey, I'm not providing this treatment because in my medical opinion, the risks and the burdens of this treatment do not outweigh the benefits of this treatment, and so I don't provide it. And that's true, again, of many other non-controversial treatments, right? There are some doctors who say, hey, I don't prescribe drug, X, because, I've done it before maybe, and I've seen in my patients, drug X, I just don't think it works very well, and I don't prescribe it, right? And that's perfectly legitimate. There's, everyone recognizes that doctors have to go on what they believe is best for this patient in this circumstance. And again, medicine is not mathematics. It's not as if, well, the right answer is, 7 + 5 is always 12. It's universal. There's no variance. In fact, medicine, you might say, is a practical science or a practical art almost, where you're taking, you might say, universal knowledge about the human body and about treatments, but then you have to apply them in particular cases. And many medical professionals can and do disagree. I mean, even treating this very same patient, right? You often have, I'm in the ER and I'm suffering from whatever, and you might have 3 doctors who have 3 different opinions about exactly what's wrong with me. And even if they agree with what's wrong with me, you might have 3 doctors having 3 different opinions about exactly what the best treatment for me would be. So this is very common, and it seems to me at the end of the day, this can be also a matter of conscience. In other words, you can imagine a doctor saying, look, I appreciate you're saying, this patient needs this treatment, but I honestly don't think that's best for the patient. In fact, I think it may harm the patient, and I'm refusing to do that because I really believe in conscience providing this treatment is going to be detrimental, so I'm not going to do it. I think that that's a legitimate thing for a doctor to do, and it's something that actually I think helps the medical profession, because when you have doctors who and nurses and healthcare professionals who are able to think outside the box, this actually can greatly help many other people. So let me give you a concrete case. There are some physicians who do not provide contraceptives. And as a result of this, they advocate for what's called natural family planning, or sometimes also called fertility awareness methods. And so basically over the last 30 or 40 years, they have really enhanced these fertility awareness methods so that now we can, better than ever before, determine at what point in a woman's cycle she's likely to get pregnant and at what points in her cycle she's not likely to get pregnant. So you might say, okay, who cares? That's, how does that help everybody else? Well, it actually does help everybody else, or at least everybody who's struggling with infertility problems. So those very same methods now can be put to a different goal. That is to say, there are many couples that struggle with infertility. And so now that these doctors have developed more advanced understandings of fertility and a greater understanding of how a pregnancy can be achieved, we can use that understanding to help all these women, many of them who don't share this Catholic belief about contraception, but who do want to be pregnant, and the knowledge can be used to help them. So I think conscientious objection inadvertently can actually benefit those that are totally unrelated to the concerns that originally animated the conscientious objection.
Yeah, no, I think that's a really great example to remind us of, because, in readings that I've done about fertility-based awareness, as you've said, not only does it help people who are perhaps struggling to conceive to be more aware of the natural order of things and operations, but also, going back to, the original patient, right, of the woman who might, say, be prescribed contraceptions to deal with other symptoms that she has. So say a woman who is experiencing severe pain every month. Well, rather sometimes I've heard than looking into the cause of that, they say, well, if you're having a pain associated with your cycle, just don't have a cycle, therefore there's no pain. But the underlying condition is still there and being untreated. And it seems like a conscientious objection to, say, the automatic prescribing of contraception might in fact be a detriment to women's health in certain circumstances. And I think it's, the example that you brought up is really important to be aware of, that there can be conscientious objection even to these sort of debated areas of abortion, contraception, but that are really should not be debated, right? Women's health should not be that we're debating. And perhaps a conscientious objection to this particular treatment might, in some cases, lead to an increase of the quality of care that a given woman receives.
Now, that's a really good point. And I can give another example along the same lines. So couples that are struggling with infertility often or sometimes have recourse to in vitro fertilization. And as you probably know, in vitro fertilization is one of those kinds of treatments that some people conscientiously object to. Now, if you conscientiously object to, say, using in vitro fertilization, what alternatives are there? Well, given their conscientious objection, some physicians did look into alternatives, and they actually discovered various treatments for infertility that were underutilized or not known before. So there's actually quite a long book called NAPRO Technology that basically talks about all the different ways in which infertility can be treated. So in other words, the idea would be if a couple is struggling with infertility, rather than say, well, tough luck for you, here, we'll do in vitro fertilization. I hope you have $15,000 in your pocket because insurance doesn't cover it. And as you may know, it only works about 1/3 of the time, so don't worry about all the miscarriages and stuff. I mean, all that's a big burden on couples that are struggling with infertility. By contrast, NAPRO Technology ended up having about a 70% success rate. So IVF has about a 30% success rate, and NAPRO Technology had about a 70% success rate. And it was normally covered by health insurance. So you have something that's cheaper and more effective in delivering what the people want. They want to have a baby. And all that is developed on the basis of ultimately conscientious objection. So I think that it really is a mistake in narrow thinking, one factor analysis to say, well, all that matters is, providing the in vitro fertilization or providing the birth control. But in fact, there are these other factors that are quite relevant and important for the good of health overall, considered, and even for healthcare of, more than just the people involved, in other words.
Right. Wow. No, that's a really interesting point, I think, and how wonderful, really, that something that begins as an objection to a certain practice can lead to all of these discoveries. That's really, really important to remember, I think.
Yeah. I do want to just clarify one thing, though, and I didn't talk about this in the paper, but it might be relevant for our discussion. I think on a Catholic view, at least if you define contraception as any action which before, during, or after the sexual act is intended to render the sexual act non-procreative, that it actually would not be contraception for a woman to take a pill to regulate her cycle or to stop her cycle, if the intention of doing that was simply and solely to stop the pain or to get rid of the whatever problem she's having. So you can imagine, for example, imagine a sister in the Missionaries of Charity. So she's not having sex with anyone. She's a religious nun. She's celibate, and she could, it seems to me, take the contraceptive pill, but not take it as a contraceptive. So let me describe what I mean. It's possible to use a contraceptive device, I think, in a non-contraceptive way. So if I were to get a condom and make it into a water balloon and throw it at my brother, that action is not properly described as using contraception. I mean, yes, I am using a contraceptive device, but I'm not using it qua contraceptive. So I think arguably, if you had a case of a woman who took the contraceptive pill, but not for the sake of making her sexual acts non-procreative, but solely for the sake of regulating her cycle or whatever, that properly speaking, I don't think that would be contraceptives or contraception if you define contraception in the way that I did. But that's sort of getting off topic. So maybe you can just ask your next question, because I realize it's a little off topic. I just wanted to throw that out there.
No, that's a very important. And one thing that I appreciate about this essay is all of the distinctions that you draw. So that's helpful. It does seem to me, though, that Going back to the example of taking contraception, say taking the pill for something other than contraception, could still be something that could be conscientiously objected to if, for example, you say, in my patients that I have prescribed this to, I have noticed these, or in cases similar to yours, I have recognized that this is not the most effective treatment. But still, I think the distinction between taking contraception qua treatment of, say, pain versus contraceptive qua, stopping the implantation of an embryo, et cetera, is very important. Perhaps for the last question, speaking of distinctions that you draw, I was wondering if you might say something about the distinction between a liberty right and duties of cooperation, because you make the point that if abortion is a liberty right, then like other liberty rights, it does not involve a duty of cooperation from other people. And I was wondering if you could speak briefly about what exactly a liberty right is versus a duty of cooperation, if there is any liberty right that necessarily involves a duty of cooperation, say by an individual or by an institution. But if you could perhaps clarify those distinctions a little bit, it might help this conversation as well.
Sure. So I was drawing a distinction between a claim right on the one hand and a liberty right on the other hand. And the distinction is that in a claim right, I'm saying I have a right to something and somebody else has a duty to provide that for me. So for instance, the right to healthcare would be an example of a claim right, right? I'm saying, if I say I have a right to healthcare, that's another way of saying other people, the government or whoever, have a duty to provide me with healthcare. A liberty right, by contrast, is the idea that I have no duty to not do the thing in question. So an example of that would be, say, the right to free speech. So I have a right to speak freely. That's another way of saying there's no duty I have not to speak freely. Now, the difference is in part the responsibilities of others. So in a claim right, other people have a responsibility to do something or not do something for me. So if I say I have a right to healthcare, that's another way of saying someone, I guess the government, has a duty to provide me healthcare. Or if I say I have a right to live, that means that other people have a duty not to intentionally kill me. Or if I say I have a right to be free, that's another way of saying other people have a responsibility, a duty not to enslave me. But a liberty right's different. If I say I have a right to free speech, it doesn't follow at all that the New York Times has to publish my op-eds or ABC News has to televise every speech I give. Right? They're under no obligation to cooperate with my liberty right of free speech. So if we think of abortion as a liberty right, then if it's a liberty right, then other people just have no duty or obligation to provide me with that. If, on the other hand, you think of abortion, say, as a claim right, that my right to get an abortion is somebody else's duty to provide me with an abortion, well, then we have to dig deeper. The question then would be, well, is this a legal duty or a moral duty? And in the United States, at least, there is no legal duty for a conscientiously objecting physician or institution to provide abortion. After Roe versus Wade was passed in the 1970s, there were, the Church Amendment was passed, and that basically said that there is no duty of people who conscientiously object to provide abortions. On the other hand, if you think of the question as a moral duty to provide it, well, then the question arises, of course, well, what's the basis of this moral duty? You can't have a moral duty to do something that's morally wrong. So, and this might circle back to the question at the beginning. If it turns out that abortion is morally impermissible, well, then it's impossible that there's a moral duty to do something that's morally impermissible, right? That's just a contradiction. You can't have duties to do what you have a duty not to do, right? That doesn't work. So if you think of abortion as a claim right, and it is a moral duty to cooperate with that, that presupposes that abortion is ethically permissible, and that is something that is at least questionable. So in the paper I'm criticizing, they don't provide any grounds at all for thinking that's true. And so ultimately they provide no grounds at all for thinking that abortion is a moral claim right.
Mhm. No, thank you, because it really does seem in the essay you're responding to, Shuklink and Smalling, that they really do seem to be equating liberty rights with claim rights. And that does bring us back, as you said, to the question that started this discussion off, which is, well, if the the claim right, say to abortion or to euthanasia or to all the other treatments that we've talked about today, is in fact a claim right and not liberty, then that's assuming the permissibility of it. But, obviously based on their writing this essay and you're responding to it and countless other authors and thinkers and doctors and practitioners, this is not something that has been perhaps definitively stated. And it was really interesting to me with this distinction between claim rights and duties and liberty rights, that if you are going to argue on the basis of liberty against conscientious objection, that you are in fact not saying that a particular objector has a duty to do something for you, which also ties into, I think, the questions we had about individual doctors, say, and the medical profession. So the example of the doctor that you brought up, Dr. McKenzua, whose story really struck me, saying that perhaps there is a duty in the medical profession at large to make sure that women seeking abortions have access to services, does not entail that each and every individual practitioner be forced to do that. Could you expand a little bit on that? Because I think this sort of ties together some of the distinctions you were just bringing up.
Sure, yeah. So the idea there would be that they make a claim that because doctors or healthcare professionals have a monopoly on providing services, therefore they have a duty to provide those services. But I think they fall into a fallacy of thinking that some property that the whole has an obligation to provide, therefore each individual part of the whole also has that obligation. And that seems like clearly fallacious thinking. Like if you say, this entire wall weighs 1 ton, and therefore every brick in the wall also weighs 1 ton. That's obviously a fallacy. So you could hold that the whole healthcare profession has a monopoly, and therefore the whole healthcare profession has a duty to provide these services. But it doesn't fall from that every single individual in the healthcare profession has a duty to provide these services. And in fact, they don't, right? In other words, there's no duty of the brain surgeon to perform a foot surgery on me, right? In other words, we already do recognize that the responsibilities of medical professionals already are diversified, and people have specialties. And if you're in one specialty, you have no obligation to provide the treatment that's totally in a different specialty. So, and that's good, right? In other words, we're all better off that there is specialization, that not every doctor can and should be and needs to be an expert in everything. Because if you really demanded that, then that would greatly decrease the quality of healthcare, right? Because part of the reason a brain surgeon can be really, really good is that they do brain surgery and they study it for, years and years, and they do it every day. And therefore, after doing it for 20 years, they're absolutely fantastic. If they only did brain surgery, once a year because they were busy doing foot surgeries and busy treating asthma and busy doing all kinds of other things, obviously they couldn't really specialize and they would be less good at their job. Anyway, so to go back to the conscientious objection, the idea would be that even if it's true that the healthcare profession as a whole has a monopoly and therefore has a duty to provide healthcare services, it doesn't follow that each individual participant in the healthcare profession has the same duty.
Excellent. No, thank you for that, because it really does seem to be directly related to the question of conscientious objection, the question of personal liberty and the ability to choose to act in accord with your conscience, even when there are pressures not to do so. And it seems like a lot of the objections in this essay don't take into account all of these other consequences towards forcing someone to do a certain action, even against their better judgment, even against their conscience. And so while I think this is super important, and of course, obviously applicable to healthcare, it's interesting to start seeing all of the consequences which could follow from that general principle in regards to personal liberty and autonomy as well.
Yeah, thank you, Catherine. Yeah, and I want to thank you for making time to discuss this paper with me, and you did such a careful job reading it and analyzing it and came up with so many good questions. So thank you very much for that. And let me
Yes,
just,
thank you.
yeah, and let me just conclude also by thanking the Academy of Catholic Thought and Imagination at LMU for the support of my research. I appreciate that a lot. And, you know, I'm looking forward to further collaboration with them, and obviously, Catherine, further collaboration with you. And so that'll bring to a conclusion our discussion today. Thanks very much.
Absolutely. Thank you so much. I really benefited a lot from studying this and from our discussion.
Excellent. Good.